So I wish to congratulate Krzysztof ZIENIEWICZ for this magnificent organization and Professor BISMUTH for yet another brilliant supervision of his students. And all of you, and I miss you very much, and hopefully we'll see each other soon in person. So I wanted to talk about autoimmune diseases. These diseases are complicated by an increased incidence of rejection, particularly an increased incidence of steroid-resistant rejection, as well as antibody-mediated rejection associated with DSA, donor-specific antibodies, which either arise are from the donor or de novo. Also recur. This is the thing we are very interested in. In general, most transplant teams manage these patients with more immunosuppression, leading to long-term complications of immunosuppression, including graft versus host disease. This is important to our practice in particular because we take care of so many children. And children need to live a long time. And a 5 or 10-year graft survival is not good enough for an adolescent. Retransplantation is a challenge. And the biggest irony is that patients with autoimmune liver disease are frequently excluded from trials of immunosuppression. The innate environment of the liver is generally what we call regulatory, which means it downregulates inflammation. This would include dendritic cells, Kupffer cells, and the architecture of the liver that permits the body to handle and downregulate inflammatory stimulation. However, the liver immune environment contains T cells which are skewed, meaning more prominent in the effector memory phenotype, meaning that the liver is a repository of the body's memories, perhaps as much as the brain. There are increased NK cells, gamma delta T cells, which behave uniquely in response to adaptive stimulation. And finally, there are also memory B cells, which remember antigen stimulations. They're probably regulated by T cells. But the memory B cells lead to the autoantibody responses. Now, autoimmune hepatitis and PSC in particular tend to happen in younger patients, younger people and children. And so these are the diseases we're most concerned about. Autoimmune is a complicated set of disorders associated with hypergammaglobulinemia, specific autoantibodies, interface hepatitis, rich with plasma cells, and there are different subtypes, and it is hypothesized that impaired T regulatory responses are an important part of it, and they have been associated with, but not universally, with a genetic predisposition. So in patients, particularly those young patients who present with acute autoimmune hepatitis, it is not uncommon to have serious recurrent liver injury within the first 5 years. Long-term survival becomes a big deal. PSC, you're all familiar with it. I don't have to go into detail, but again, T cell dysregulation, gut inflammatory upregulation leads to recurrent disease. Now, rejection after liver transplant in general is T cell driven. This is the effector memory we talked about. And there's a lot of B cell cross-reactivity, which is why there's an emerging concern with the risk of antibody-mediated rejection. It's a controversial topic, but I think it's real. Certainly in pediatric liver transplant recipients followed out beyond 5 and 10 years, we see development of autoantibodies and de novo DSA in a substantial proportion of patients. This reactivity is to both HLA and non-HLA antigens over time. after transplantation of the liver. And we know that de novo DSA is associated with concerning histology. The most dramatic illustration of this is in the tolerance trials, when you have a bunch of kids that you think you might be able to wean from immunosuppression. You do baseline biopsies and you find that a lot of those livers have either fibrosis, silent fibrosis, or occult inflammation. Now, we looked at our nearly 300 autoimmune patients in our series. You can see most of the patients, particularly in the autoimmune group, as well as the PSC group, are under 40 years old. So this is a young demographic. It's also very important to note that Black patients have an increased representation of these autoimmune inflammatory disease. And we know that Black patients in general have lower long-term graft survival due to a complication of factors that are likely immunologic. The rejection risk, and maybe this is a little exaggerated, we looked at a recent group over the past few years and found that if you are very strict and aggressive at diagnosing rejection, nearly half of the autoimmune, the younger autoimmune and PSC patients will have at least one rejection in the first year. So this is a big target that we might be able to challenge with novel immunosuppressive strategies. Another view, if you take the long term, these are sort of, let's see, 10-year, 20-year survival. We're really looking at these patients with about a 50% 20-year survival. Okay, that's not a big deal if your patients are elderly or 60 plus, but if the patients are under 40 years old, you see the long-term survival is only about 50%. If these patients come to retransplantation, the 10 and 15-year survival is less than 25%. And again, we see this concerning demographic risk of rejection in Black patients. We're using an approach, this is Megan Sykes, who leads our immunology program, to identify donor-reactive T cell clones. She did this to study the tolerant kidney transplants. And so you can extract T cells from a pre-transplant patient and identify potential donor-reactive clones. Those clones are deleted in patients who are tolerant or accepting kidney transplants. Whereas in patients with kidney transplant, particularly those who are rejecting, the donor-reactive clones that were present before transplant are upregulated in rejection. In a well-functioning liver transplant, donor-reactive clones are decreased. However, in both intestinal and liver graft and kidney rejection, donor-reactive clones are increased. This is all quite logical. And we brought these same approaches to test the hypothesis that autoreactive clones, autoreactivity that was present prior to transplant, might be detected after transplant. And what was most interesting was to answer the question, are autoreactive clones active in patients who we think are having rejection? So these are, now this is a sort of preliminary data showing the different types of T cells. And you'll notice that tissue-based fractions are much more different than circulating serum. So some of us who would like to be able to monitor the immune system from serum have to take caution in this. You see opposite relationships of the CD4 between serum and blood, whereas the alternative CD4 markers have a much different relationship. So you have to take caution when interpreting serum markers and making assumptions about what's going on in the organ. Now here's a nice illustration of autoreactivity. This is a patient who is with autoimmune and PSC, an overlap syndrome patient with classical acute rejection at day 69. Now, day 69 is unusual time to have rejection, but apart from that, the biopsy was very typical. And yet, if you see this analysis, the autoreactive clones were far more prominent in this patient than the donor reactive clones. So this was an example that sort of went along with our concern that autoreactivity might be more important. And here's a group of patients that were accumulated, and including the total frequency as well as the fractions, were much more prominent in these dozen patients or so who are having what was diagnosed as rejection. We looked at a relatively small group of patients with a variety of syndromes, all of whom had significant and classical BAMF rejections, a little bit strong, 5, 6, and 7. And you can see the comparison of the donor versus the autoreactivity. And in many of these patients, but not all, the autoreactivity was much more pronounced than the donor reactivity. The other thing that's interesting is these last 3 patients were controls without autoimmune disease, and we still see autoreactive clones present in the setting of rejection in these non-autoimmune patients. So the story is quite complicated. Here's another single patient example of the amount of autoreactivity here in red, these big bars, compared to the donor reactivity for an individual patient rejecting on day 9 post-transplantation. So we thought about this a lot, and we've gone back to a very nice paper written by Jan Lerut about 15 years ago, who was one, of course, a dear friend and compagnon, who studied the use of anti-CD2 in liver transplant patients. Now, CD2 is a ubiquitous marker in T cells, which is both co-stimulatory as well as, depending on how the antibody is formed, the blocking the using anti-CD2 can get rid of effector memory, as well as actively responding T cells, and yet preserve regulatory T cells. It's a very interesting and unusual drug, which we have gotten a hold of, and it is now available in a variety of clinical settings. It hasn't been used in humans much. It's been used in lymphomas, in bone marrow transplant, and it was the centerpiece of the Mass General and Columbia tolerance studies in which kidney transplant immunosuppression was withdrawn. We think this drug, as did Jan nearly 20 years ago, might have a great deal of interest in liver transplantation for both tolerance induction as well as the possibility of using it as a in the setting of a multi-drug immunosuppression induction, particularly in autoimmune patients. We have been studying mixed chimerism, which is the approach of that was used to get tolerance in the Mass General protocol in kidney transplants. Interestingly, when we've tested it in the monkey liver transplant model, this mixed chimerism with bone marrow does not result in long-term tolerance. So we're exploring alternative pathways, including control of T regulation. So when we come to the clinic, which hopefully will be soon, with tolerance trials in liver transplantation, Ciplizumab will be at the center of these strategies, along with administration of T regulation. The other thing to say is that in parallel with the tolerance trials, we are anticipating, hopefully in the next 6 to 12 months, initiating a Ciplizumab trial in autoimmune liver disease. So in conclusion, now that the hepatitis C patients are no longer a factor in complicating our lives as liver transplant doctors, autoimmune liver disease is a critical frontier in both understanding and controlling the immune response in liver transplantation. It is pretty clear in our minds, I'm not sure the data are strong enough yet to prove it, but we are convinced that both antibody-mediated rejection and chronic rejection is potentiated by autoimmune responses certainly in autoimmune patients, but probably in other transplant patients as well. In other words, the presence of an allograft can stimulate autoimmunity even in a non-autoimmune recipient. The key to all this is effector memory. These effector memory cells, which are mature and able to respond to either auto stimulation or donor stimulation, those cells last for years, sometimes decades. Controlling those cells with a selective agent is the critical barrier, in our view, to advancing both the treatment of regular allotransplants as well as the frontier for tolerance. So therefore, ciplizumab, in our view, is going to be an optimal agent to introduce to the clinic. And this will be the first step to trials in tolerance. I thank you all very much for your attention.
Thank you for your lecture. Do we have any questions, any comments from the audience? We have one.
Hello, Jean. Nice presentation. One remark and one question. The remark is that the compliance of these young patients with autoimmune disease is very poor before transplantation, and it is a reason for premature transplantation, and also very poor after transplantation is a confounding factor. And the question is the recent term of plasma-rich rejection. You suggest that it's rather a recurrence of autoimmune disease rather than a special rejection. Can you comment?
Yeah, that's a really important question. The difficulty we have with the teenagers and adolescents is definitely complicated by the fact that they don't always take their medications. But now, as far as the second part of your question, the plasma cell rich variant of rejection is probably driven by both donor reactivity and autoreactivity. Plasma cells are not unique to autoimmune liver disease, and it is very clear that T cells that are responding to any antigen, whether it's donor or autoantigens, can stimulate the B cells to become activated. The B cells mature and form plasma cells. So I think both auto and allo responses can lead to plasma cell rich liver graft injury, which, by the way, as I'm sure you know, is very hard to treat with our conventional medications.
Okay. So thank you so much, Jean.